Testing mic. Test.
You okay? Good. Can you hear me at the back? Okay, excellent. Just a little bit show it to it, right? Yeah, good. Good. So extremely important to prepare the patient. Yeah. So I'll keep talking, and so it's very important to prepare the patient for the study. And she's had the studies before, but many times the patient will come to your lab when they have not had the studies. And electrical stimulation can be scary. So prepare the patient well, let them know what to expect. And then, as Dr. Ahmed was mentioning, having a plan. So I'll start just to show you how the commonest nerve, median nerve, is done. First important thing is to make sure the patient's skin temperature is warm enough, because cold limbs can have a major effect on your nerve studies, particularly the conduction velocities, latencies. Her hand is nice and warm, but all labs do have heat packs or whatever to warm the hand. And so make sure the study is done at a particular limb temperature, ideally 32 to 33 degrees Celsius. Okay. The second important part is to clean the hand or the limb because of oil and other lotions, because that can really introduce artifacts. So can I have an alcohol, please? So that's the first thing we'll do, is to clean the limb with, take off all the lotions. I'm just going to clean it, okay? So I'm just going to clean the limb, make sure. So we'll start with the median motor. I'll show you median sensory. So I'm just going to clean the whole hand, good, nice, take away all the lotion. Then you can see that the lotion is coming off too. So it's very important to get off all the oil and things. The other important thing is to have the limb perfectly stable. One of the commonest mistake in the nerve conduction study is movement artifact. The limb should be very relaxed, and the muscle should not be, the patient should not be holding like this, because it will induce artifact to your study. So nice and relaxed, a resting position. And can I have the electrode, please? Can you join me? Recording electrode. So in the first, ideally, we should put the ground electrode first. Is there an empty chair over there because it's too far? Yeah, you got to come over here. So the black is the active electrode or the recording electrode, the reference electrode. Now I was listening, and whatever I could understand from Dr. Ahmed, these are the two, the electrodes need to be very nicely attached to the skin. There should not be any gap, introduce an artifact. The positioning of these electrodes is very important. When the potential goes down, the black one, he was talking about phase cancellation, I could hear that. And what happens is this electrode and this, they compare each other. When the potential is passing under this, the other position is, other electrode is, the reference electrode is neutral. If they're too close together, he was mentioning about phase cancellation, because both will record at the same time the same potential. So ideally, they should be at a particular distance. For motor studies, they were mentioning about belly tendon. Make sure that the muscle is on the motor point. Motor point is the place where the nerve enters the muscle. If you're off the motor point, there will be an artifact. I'll show you all those things. So for APB, abductor pollicis brevis, it's a nice belly. It's easy to do. And I put it typically, normally it is, pass me the tape, please. So I'm used to a bit different electrodes. It'll take me a little while to fix these. But can you see the hand? Good, excellent. So ideally, the muscle belly right over here, and I suspect this is the motor point. I'll know it once I finally, a very small tape, not that big, half and half. This is half. That's good, okay. So I'm going to put this tape right across, and I'm going to firmly apply this. We applied the gel also to improve the conductance, and the electrode being firmly attached to the skin. The reference electrode, the red one, would go to the tendon. Now, if I apply too close to the belly, it will record the same potential. The amplitude will be at field. So I have to go make sure. She's got a bit small hands. Typically, we apply to the first MP, but we can do a bit distally to a tendon. And here's probably there's no muscle, only tendon left there. Firmly attached it to the. So each muscle has got a different length. So if you are doing tibialis anterior, you might be going belly and tendons much farther. So there's no fixed distance as compared to sensory, where there's a fixed distance. We'll talk about that. In muscles can be different. It can be at different points. So ground electrode, ideally, we would like to apply between the reference electrode and the stimulating electrode. So ideally, we should, to reduce the artifact. Do you have something? I don't want to break the wire. I'm just going to use this. Yeah, this is that's too thick or something because it's not going. But thank you so much. For now, it's good. And here's the ground electrode. Ideally, I should be a little. Okay. So motor studies are done at a particular distance. The difference varies in the labs. So each lab has their own values. Make sure when you look at a study, the reference values, and you're following a protocol, you follow the same protocol. Many labs have got different protocols. For our lab, here's the measuring tape. Do you have the measuring tape, please? The measuring. So for medial motor, our lab uses 7 centimeters. Okay? We don't have a marker, otherwise I would have marked the skin before, but 7. Okay, you got the marker now? Okay, so maybe, okay. So 7 centimeters, measuring the median nerve. Tape, a little bit tape, please. So, I think the recording electrode is a bit loose, and I'm very particular about that because, yeah, good, okay. So 7 centimeters, following the course from the middle of the electrode, following the course of the, is there a marker? Can you open this marker, please? Okay. Okay, so this is approximately 7 centimeters, okay? And the median nerve, if you make a fist, is next to the palmaris longus tendon right over there. So stimulating electrode and the cathode and the anode, okay? And the gel a bit. It's a small one. So when you apply gel, you make sure you don't apply too much. If you apply too much, either there or over, it can make a bridge between the two. So just want to enough to have a good contact to the skin, but not too much to make an artificial bridge, okay? So we'll start stimulating. Please. Okay, start very gently. Oh, no, did you know it was too hard? Okay, look, start 0. Okay, she's a very thin person. I expect to get a motor response very early. So I'll start very gently start at 0. Before we do that, just want to make sure that the baseline is good. Is this all the artifact there? You can see there's a lot of artifact coming. So always keep an eye on so just relax your hand, please. This is called a 60 cycle artifact. In motor studies, it may not be that important, but in sensory studies, it becomes very important because sensory studies are looking at very small potentials, and these artifacts is better now. So let's start. Let's see what the motor nerve shows. So you go by. So you can see this current strength up there at about 2.3. That's fine. Just give the stimulus, please. So I can see. Even now, you don't see a response there, but I can feel her muscle twitching. Okay, so that small. So each patient is different. Her wrist is very thin. Go up a little bit more. Go ahead. Yep, I can see the stimulation. Okay, keep going a little bit more. Okay, where are you now? Yeah, you can see by within less than 10 milliamps, you got a nice and good response. Okay, now this patient is very prone to getting overstimulated. The nerve is very superficial. There's no fat, much fat. So in a bigger person, I saw Dr. Ahmed mentioning 60, 50, 60 m. You don't go there. You start very gently. So you're getting a nice response right there. Do you have a pointer, please? A pointer. No, the pointer to the screen. You just had a pointer, Dr. Ahmed. Yeah, thank you so much. Sorry. No? What's that?
It's not connected with this laptop.
No, but I want to just do the screen. It shouldn't. Oh, I see. Okay, no worries. Is there a mouse over here I can show? Oh, yeah, here. Okay, I'll do that. So you can see few things before you start. Okay, first thing is look at the baseline. Baseline has to be flat because your latencies, distal latency or onset latency was mentioned, depends on your baseline. The baseline, the first thing you want to see is this is the stimulus artifact over there, which is showing, and then you go to baseline, and this is your distal latency. And if the baseline is not flat, it'll be abnormal. The onset, the peak, the onset of the response should be sharp. Okay. If you're off the motor point, if I had more time, I would have shown you what the difference is if you move the electrode off the motor point. Okay. So right now, that's fine. So nice, thank you. So flat baseline, nice rise time, nice sharp takeoff. Sharp takeoff is critical. Okay, if so when you look at the quality of the nerve conduction, you want to see the sharp takeoff. Okay, the response is cut from the top. Is it can you reduce the gain? No, the other way, even less. Can you reduce it further? Yeah. Okay, one more time. Can you give the current again, please? Go, yes. So now you can see the nice peak. Okay, I reduced the gain. You can see the settings now, and it'll show you where does it on the screen? No, no, on that the millivolts and the gain and the sweep speed, right there. They can't see it. Okay, on the right side you can see the latency, onset latency 3.3. Okay, and the peak amplitude is 9.8. Yeah, okay. So latency is 3.3 onset, amplitude is 9.8. Okay. Now, you were mentioning about supramaximal. What supramaximal means is the amount of current I apply, I want to make sure that all the nerves under my stimulator have been activated. So when I get the maximum amplitude, I go above that by about 10 to 20%. So let's say that till 10 milliamp current, I'm getting this response. I might go to 12 to 13 to 14 to make sure everything's stimulated. My stimulator has to be right on the nerve. If I do, it's off the nerve, you require more current. So that's why it's very important to have stimulator right on top of the nerve. So you use minimal current, and then when you reach the maximal amplitude, you go to supramaximal. So right now, the current is, if just give me a second. Here. So you can see that it's 11 milliamps we are getting, and this 200. The sweep speed is 200. Is it 200 microseconds or 2 milliseconds? 11 milliamps is the current. So let's go to 13. Let's see if it still increases. Just look at the number and go to 13. No, not that much. 13 can load. So that's good. So you can see that it didn't go up. So I've reached the maximum at 12 or whatever, and by 15 I've reached supramaximal. Okay. So what the other thing you're seeing is if you slightly increase the current to about 20, so that's fine. And now stimulate. No. Go ahead. So I'm not seeing over here, but previously I saw an F wave, but we'll talk about that. So that's the distal stimulation. Now I go to the proximal stimulation now. The proximal stimulation point in the median nerve is right next to the biceps tendon, just middle to the biceps tendon up over here is the proximal point for the median nerve, okay? The thing what I want to make sure when I am up there is that, don't stimulate yet, okay? Is I want to reproduce the same CMAP up proximally and distally. There should not be much difference in shape, that's very important. Shape and amplitude in a normal patient, the proximal and distal responses should be similar in shape, morphology, and size. What's it? Yes. Oh, okay. But they will, her hand will jerk. If her hand will jerk too much, you know the rest, there'll be a lot of movement, that's why. Because the problem is, she said that we can put it like this, when I stimulate proximally, the whole hand will jerk, you'll see that. And so, yes, I noticed that, but the problem will be, it'll cause some, so I want you, so just to show you, it's right, make a muscle bend, it's right, the biceps tendon right here, the median nerve is right next to it, okay? And so you know the anatomical points, and I'm just going to go there to make sure that there is minimal movement artifact. The hand has to be resting. If I do that, because the median nerve supplies the whole flexor compartment, plus your hand, so the whole hand will jerk. And in motors, because you'll see that shortly, okay? So just start very gently at about 5. Again, you'll see, okay. Okay, I can already feel the contraction of the hand. Okay, a little higher, please, to go to about 10. That's good. You can also, by 10, I already got a good response. Distal latency now, I'm getting 7.3 with amplitude of 7.8. There's about a 20% drop there. So this is a common artifact. If I don't go up on the current, you get a 20, somebody was mentioning a conduction block, 50%. 50% is an absolute conduction block. But the moment there's a drop of more than 10 to 15%, I get suspicious. Proximal and distal stimulation should reproduce the same amplitude roughly. Anything above 20% or 20%, some people call it partial conduction block. So that's very important. If you're documenting partial conduction block, you're implying either there's a focal demyelination or the patient's got some issue. So this is not, but just for quality check, you can see the response has got similar morphology, roughly similar duration, but let's talk about going a little bit higher now. Go about 15 or so. Yeah, go ahead. Now, so it's now 10.2. So what happened there? Now it's higher than the distal amplitude. Now, why can that be? What can be the problem? Most likely is understimulation distally. I was being gentle with her. There is an understimulation distally. They should be. So you can see the nerve is much more, over there distally it's among the tendons. But over here the nerve is much more superficial. And so you can easily I would like to have the similar amplitude as similar as possible, okay? So having the marker, just go up a little bit to about, just before we do that, go to about 18 or so. Now stimulate, please. So I've reached supramaximal, you can see that. So I know that 10.2 is there's no reason in a normal nerve why the amplitude distally should be bigger than, approximately should be bigger, because the same nerve fiber is going to. So let's go down. I'm just going to mark over here. I don't want to give it too much stimulus. I just want to make sure, although this may be acceptable, but I want to show you. So go, okay, again, go down to the current. Go to about 15, please. Yeah, now go ahead. So now you can see I got, see that it went to 10.7? So you can see I just showed you, and now, so you can see what understimulation, overstimulation. I haven't shown you overstimulation, I've showed you understimulation. And I'll measure the distance between the 2 points. It's about 210 or 21 centimeters or 210. Can you put the distance, please? 210. So now I'm going to collect the conduction velocity of this nerve. So I showed you the proximal and distal simulation, measuring the distance. Distance measuring errors are very common, particularly at 2 points. Ulnar nerve and peroneal nerve, those are common nerves involved. Because the ulnar nerve goes around the bend, you have to make sure that ulnar response, when you obtain at a bend and measure the nerve along its anatomical course. If you measure the nerve straight like this, it will be much shorter. But so same thing for peroneal nerve. When you stimulate below the fibula and in the popliteal fossa, the distance between the 2 points is critical. So distance measuring errors at these points are common. Okay, so the conduction velocity over here is 53 meters per second. Based on the formula, you subtract the distal latency from the proximal latency. This is the time. You already measured the distance to 10 centimeters. Distance divided by time is conduction velocity, and you get 53 meters per second. Again, sharp rise time, similar morphology, duration, and if you see there's a, let me try one thing, or maybe I can show you an artifact. So this is normal, okay? Let me show you if I can you ask, is she okay? You okay? Not too hard, no, it's good? Okay, yeah, okay, okay. I'll show you something over here, if I can. It's a nice, she's a nice patient because she's got 10 arms, and so I can go to the stimulator a little bit at around 20, 25 or so. I'm going to hold the hand. Yeah, go ahead. Yeah, go ahead. Yeah, it's not. Can you increase the gain? Okay, it's about to show. If you increase the gain, you see something over here which I wanted to show you, and that's very nicely. It's just a part. You know what I'm trying to show you over here? Who can tell me that? There's something changed that happened. Exactly. Huh? Not. Yeah, that's true. But something more that is showing. Showing this positive dip over here. You see this? There's a little dip going downward. So in convention, the downward is positive in nerve conduction, okay, EMG. So when I say positive, it means it's going down. This positive dip is a nightmare. It can cause a lot of problems. This positive dip is happening over here because of volume conduction. Volume conduction is something, when I'm stimulating this median nerve there, it's stimulating a lot of muscles. And those muscle potentials are also being recorded. Some of them are reaching the recording electrode earlier than at the motor point. So just to explain to you, this is volume conduction, and if you overstimulate, this exactly, you'll see exactly this positive dip, and that changes your latency. Can you go? Can you change the latency marker? Move it back. Number 1. Sorry, this machine, I have to depend on him. I don't use this. So there you go. So go back. So now you can have an artificial. Somebody mentioning about onset latency. Because of this positive dip, you can have an earlier onset. So overstimulation, volume conduction. Some nerves, you get that even normally. When you stimulate the radial nerve and recorded the EIP, extensor indicis proprius. Because of all the muscle around, sometimes you have to accept it, and there are ways to deal with it. But in certain nerves, you shouldn't see that, okay? So this is a positive dip, and we'll talk about that in my other lecture as well. But I wanted to show you that because this is a wonderful patient because of a thing. You can easily get a positive dip in her, overstimulate. This is not overstimulation. This is volume conduction by other muscles. And the recording electrode now is also recording distant potentials. And so you get a positive dip, okay? I don't want to go in much details because then I'll keep going. I'll go to sensory now, okay? I can keep going, but anyway. So this is what is a normal median reduced gain. Any questions which I've not covered? Yes? This is physiological because this is physiological. Not this, I won't call overstimulation because now, yes, part of it is overstimulation, part of it is other muscles being so that's right. But you have to be careful. Look for this when you're doing median nerve studies. We really don't see this at this gain. We don't have to do this gain, okay? But I could see just starting to go back to the normal gain, please. So I was about to. I was just seeing. I could see it just appearing there, okay? I was just seeing it's about. So that's what I've showed you. But this is good enough. But it is also from the volume conduction of other muscle fibers. Okay, some other muscles around that. Because now you're stimulating a lot of muscles in the forearm. Previously, you were just doing hand muscles. Now, look at all the flexor compartment. Okay, and those kinds. Any other questions? Yes, sir.
Yeah, if I get a positive dip like this, should I put a marker in the beginning or should I just ignore it?
Wonderful question. At the onset of, but both potentials, at the wherever it leaves the baseline, the marker will have to go at the onset of this, at this mark. Let's see if I had to do this. Can you change the number one, the onset latency a little bit? Where you can, like this, a little bit. Let's go back a little bit. I'm just going to, no, the second one, this potential, this one. Sorry. Right there, I will put it right there. No, go back, right there. Where it's starting, where it leaves the baseline. Try to avoid it. But when it happens, you have to do same in both, okay? And you have to mark on the report. It was, I'll go over that in a second, how to report that. Any other questions? Okay, we're good. We'll go to sensory now, okay? Because we have to go to leg as well. Dr. Ahmed took away some of my time, so I'm going to go to quickly to sensory. Can you, okay, sorry, no worries. Just joking. Okay, same thing. Sensory are much more tedious because now whatever you do, the motor studies are forgiving. Sensory are not. They will show you your artifact very quickly. So again, I'll clean the nerve. Alcohol, please. If you do it right the first time, you don't have to keep going back and forth. So start making sure that, again, as compared to the motor, sensory potential is a purely nerve. You stimulate the nerve and record at the nerve. So it's a pure snap, sensory nerve action potential is called, as compared to compound wave muscle action potential. We are stimulating the nerve and recording from the muscle and the neuromuscular junction time and conduction time over here. So the other thing is sensory nerves are very superficial. You can record it both ways. You can stimulate over here and record over here. The advantage of that is the nerves are very superficial in the skin. In fact, women will be happy because you may have better snaps than males because your fingers are usually thinner and the nerves, digital nerves are very superficial. So you can anytime beat the guys. And so the other way is to stimulate the digital nerve and record at the proximally, okay? Both ways are done, antidromic and orthodromic. Those terms are used over here. The advantage is over here that you get a much better response, okay? The problem is that this is also got lumbricals and other muscles attached. So you get that response, you'll see, I'll show you. Sometimes you can get a motor artifact after that, and I'll show you that in a second. Hands had gotten cold. I'm not going to warm her in the interest of time. Our lab distance is about 13 to 14 centimeters. I'm just going to measure that and then apply the electrode, okay? The ideal place, so I'm just going to, okay. by the way, I didn't check. I should have checked that, but the conduction, I didn't see what distance he had put in for the distal latency. I had measured 7 centimeter. I didn't check the motor velocity. When we did the median motor, how much was the distance of the? Do you have that still saved? Sorry. What was the distal? What was the distance for distal latency?
210.
No, the distance for this the first.
3.1 and 6.3.
No, the distance.
Distance is 201
No,
millimeters.
wrist to AB distance. What is the distance there?
We just put one distance, 200
No.
and between elbow and wrist.
No, but there has to be a distance. So, by the way, just to avoid time, what I'm asking him is this distance. This is being deducted from this to calculate the conduction velocity. The lab usually has already set. I did it at 7 centimeters, but I don't see what. So, it may be the conduction velocity I'm showing you over here is maybe not accurate because I don't know what this machine has, but we'll do for the sensory. But distal latency minus the proximal latency is the conduction velocity, okay? But some people do it 6 centimeters, some at 7 centimeters, and that 10 millimeters makes a difference. So just didn't check that. Yeah, sensory, please. The distance, do you already have a distance there, or should I tell you my distance?
No, you should put the distance.
So 130 or 13 centimeters. Okay, her hands are short. 13 to 14 is this. Okay. Okay. So again, first putting the ground, making sure there's enough gel on it. The ground in sensories ideally has to go between the recording and the stimulating electrode. So I'll put right at the wrist over here and make it sure that it's firmly attached to the wrist. So there is no gap. There is nice gel contact of the recording electrodes and the ground electrode. The recording electrodes, please. Can you give me some cleaning solution? I just want to clean it before I go down. Give me the other gel, the thinner one, please. Okay, so now we're going to record the sensory potential, and just making sure again that there's not too much gel, but open your fingers. Okay, and right here is the recording electrode. The tape, please. Okay, that's good. And it's too much, too big. She's got small. That's good. Thank you. So ideal distance now, they say 3 to 4 centimeter. Okay, 3 to 4 centimeters. So around there, I am getting about close to 3 centimeters. The tape is coming off. Then yeah, this is good. Ideally, we have got sticky electrodes, or we can use the ring electrodes too. Do you have ring electrodes? Sometimes we use ring electrodes, which this is good. Thank you. That's fine. That's good. Okay. Pass me the tape, please. A little small tape. Good. This is good. Thank you. So distance I mentioned to you is about 3 to 4 centimeters, and this is good. We'll for now. Okay. Stimulus intensity will again start very small. Can you turn on the machine, please? And the most important part is this part. So you good? Okay. So you can see the 60 cycle artifact. up there. Sorry, I should be pointing out there. You see this is called 60 cycle artifact. All the lights in the room, and there's a filter for that. Can you put on the 60 cycle filter? And you can see it's called a notch filter. We can use the notch filter. It's a cheat technique. It affects the stimulus because it takes away some of the frequencies. It filters out, but it affects the nerve potential. It reduces the amplitude. So you can use the filter. I'm going to use it for now, but you can see. Can you switch it off now again, please? This notch filter. And you can see the 60 cycle artifact. I'm going to stimulate her with the artifact and without the artifact, okay, to show you, okay? Good? Thumbs up? Okay. And I have to make sure that I had reversed my direction. And one of the common, I wanted to show you this. This is the cathode. I was just about to stimulate her, and then checked, I said the other way. So if I do it this way, so it's called black to black. The black should be the cathode. If I reverse it, it'll give you another couple of centimeters. So it'll prolong the latency. So this is a common mistake is done where you reverse the polarity. Okay, and I had just done it. And you say, this professor is nuts, man, he's got other. So you always check in the labs, you already got the black, and so you have to make sure its polarity is right because you're adding extra density. Not only that, there's something called anodal block, where if this is in front of this, it may block the current going down to it's called anodal block. But anyway, so the right orientation, here we go now. Bismillah. Okay, put your hand. So hand again should be totally relaxed. If the muscle is not they're tight, you'll get a motor artifact. It has to be completely relaxed. And you can see that by following, switch it on. Okay, can somebody ask her to contract them? Can you switch off the notch filter? Can you put on the notch filter?
Switch it off.
No, on, switch it on. I want to show you what does the motor. So can somebody ask, can you turn the sound on? Sound on for this? Sound on. Sound. Okay, here's the sound. Ask her to contract her muscle. Let go. So when she's contracting her muscle, reduce the gain. Did you change the gain? Oh, okay, sorry. It's good? Switch off the machine. So what I was trying to point out was that you can hear the muscle being contracting. So not only look at the baseline, but at the background, a little bit of tape, please. Her hand is oily and a lot of lotion, so it's coming off a bit. The tape, please. Yes, please, just tape. Just a bit cleaner. Fine. Okay, now the tape, please. Yeah. Not sticking very well. This tape is not sticking very well. Do you have the other tape that you showed me yesterday? Like that's better. This is not sticking. That's okay. I'll see if I can. Okay. That's fine. Just relax. Just let loose. Okay. Okay. So switch on the volume, please. A little bit of volume. Not that high. That's good. Okay. So now you can see the baseline is pretty good. Okay. So the baseline is pretty good. There's no 60 cycle artifact. Let's try stimulating the nerve a little bit. Just gently, about 5 micromilliamps.
3.4.
Yeah, that's good. Go ahead, please.
Go higher.
A little bit higher.
5 is okay.
Okay, so it's going down. You can see there's a lot of stimulus artifact. You can see that in there. See this? This is a stimulus artifact. The takeoff is not clean. I want to have a very flat baseline. Okay, let's try stimulation. So now this is a great response to show you. this is not what I want to see. The stimulus is causing a lot of artifact. The takeoff is not clear, okay? Now this is something I'm going to cover again. This can be for multiple reasons, okay? It can be from the room, but also from overstimulation and how to get rid of this. I'll show you how to get rid of this. Before I do that, I want to make sure that the wires are loosely attached. That's why we can you give me some tape, please? The reason is that this is coming off. When this happens, you go back and check the electrodes, and also there are a couple of other things you can do. Yeah, this one is better. Okay, this is much better. This is much better. The other one too? Okay. Yeah, this is much better. We can do the ring electrode too, but let me just see if I can. Okay, let's stimulate again, please. That's good. So now that you can see it's better a bit, okay? Go a little bit higher stimulus. So, yes, please. No. Okay. Yes. Yes, please. That would be wonderful. Yeah, because that is. Thank you so much. Good, better now? Okay. Thank you, guys. Okay. Stimulate a little bit. Okay, nice baseline, go up a little bit. Higher? Yes, a bit higher. Okay, now just stop here. Much better than before. It's not still the best, but I don't like it, but I'll show you some other tricks. So we're getting a nice sensitive response. You can see there's a nice takeoff. You can see takeoff is nice. You can see some distant motor artifact. These are motor muscle. As I increase the current, you will see the artifact go up a little bit on the current, please. Yes, please. So you can see now, this again supramaximal. It's a nice flat, and takeoff is good. If I want to do it better, I can sometimes rotate it. You can see I'll be rotating the polarity. Now stimulate it, please. So again, stimulate, please. So you can see now, because of changing the polarity, the flat line is making big, but you're getting a more distally a motor artifact. Change the polarity again, stimulate again, please. So this is much better than what I feel which was before. So you can change, turn on off the volume. Can you do this? And you can see, can you turn on the volume, please? Volume. Volume. Sound. I can hear it. Open. You can see when she's contracting, if she's not, the baseline gets, if she was tense, and if I now stimulate it, just hold it. Right. Now stimulate, please. So you see what happened? And the muscles are a bit tight. You see what happened? It baseline. So if she was not fully relaxed, this would happen. So when your baseline, you can see what happened when I stimulate, it went all the way. It'll change your latency. I just contract a bit. Okay, stimulate a bit more. Now just relax now. So it changes your takeoff point. You can turn off the volume. So the muscle should be fully relaxed. Electrodes should be tightly attached to the skin. There shouldn't be any gap. And stimulation should be adequate for the right, because onset latency is determining your speed. So if you mark this takeoff point is very critical, where you mark it. Onset latency, peak latency. The amplitude is determined by the total number of nerve fibers stimulated. Again, we do supramaximal stimulation. Now, artificially, if you introduce the motor artifact, you can get an artificially high amplitude. I'll try it one more time. Go ahead, please, before I go to low limb. Stimulate, please. Okay, so I'm off the nerve probably. Just relax. Let go. Just let it loose. Yeah. Again, stimulate. Stimulate. Where are you? 14. Just a minute, please. Now. What's the gain? So if you look at the motor studies, you see the sweep speed over here is, I can't see it over here. What's the sweep speed and the gain over here? Up there, I could. So 5 milliseconds per division, and sorry, 10. What's the
1 millisecond per division.
per division and the gains? What's the microvolts? How many microvolts per division?
Here's the microvolts.
Yep.
10
10 microvolts. So it's you can see it's a 10 microvolts per division each, as compared to motor studies which are in millivolts. So anytime you have got an artifact there, it'll be much exaggerated. Anything about the sensory response, you can see how nice make sure you keep an eye on the oscilloscope, making sure that there's muscle contraction is not there, baseline is flat. This will determine your takeoff point, okay? Any question about the sensory, and the same principle applies to other sensory. I'll show you in the lower limb too. Sometimes we do proximal stimulation, but in sensories, there's a lot of dispersion. And so we don't do typically proximal, but in certain circumstances we can do it. It's a 1 point, you try to stimulate all the nerves under your stimulator, and you get a nerve-to-nerve response. Sensory responses are critical. They determine a lot of pathology. Localization with sensory responses is critical. So they are not involved, of course, in motor neuron disease. Radiculopathies, sensory responses are typically spared because of the dorsal root ganglion. The radiculopathies do not involve the sensory fibers in the way that where they involve it before the dorsal root ganglion. So cell bodies are intact and the distal process is intact, the axon. So you don't get sensory abnormalities typically in radiculopathies. They are critical in plexopathies. In plexopathies, they are critical because they localize the plexopathies. For example, the lateral antebrachial comes off the lateral cord. The medial antebrachial comes off the medial cord. So those responses are typical, classic, and so on and so forth. In myopathy, these are not involved. Okay, we'll go to the lower limb if that's okay with you. I'll show you a sural and a tibial, whatever. Since Dr. Ahmed already talked about F waves, can I show you the F waves now to save time? Why don't you do the F waves now?
Professor, some
Yes.
people do orthodromic stimulation,
Yes.
and some do antidromic stimulation in sensory. What do you prefer usually?
Okay, we usually do this preparation.
Yes.
You know what ortho-antidromic means? Ortho means what orthodromic means?
Also, or anti, you know the meaning?
Towards the spinal cord or against us, towards or okay. So this one is, what is this? Antidromic. Antidromic.
Against.
So we can also do the orthodromic. I'll do an orthodromic for you, okay? And that will be the median and lateral palmars. We do that commonly in, do you use palmar studies in carpal tunnel? Mixed palmar studies. I'll show you one, since we are doing it. It's a common study we do, okay? So we stimulate the median and ulnar nerves in the palm and record at the nerve itself, okay? Those are called mixed palmar studies. Very useful in carpal tunnel syndrome because the sensory studies in median and ulnar are different. The distance between this and this is distance, about 13, 14 centimeters. For ulnar, you've got 12. So you're not comparing the same distance. Over here, the distance is the same, 8 centimeters. You do it orthodromic, and the latency difference is very critical. I'll show you that in a second, those responses. Just because you asked them, I'm going to. So typical distance is, I'm just going to hold the pillow over here. Now that's good. Now we are, oh, that's good. Figure out, okay, so here we go. So 8 centimeters, give me the tape measuring. And so we measure 8 centimeters, okay, for both nerves. So stimulating at, you can see the palm, the median and ulnar, and measuring 8 centimeters for both, okay? So 8 centimeter for median and 8 centimeters for ulnar. So, okay. So we'll attach, give me some gel please, and some tape please. So we'll doing some tape please. Thank you. You're good? So, again, 3 to 4, it's a mix because you're stimulating the mixed nerve. Yeah, that's the thing, that's a problem. Good? Yeah, another one, please. Another tape, no tape here. Yeah. A little bit of paste, please. These are easier studies to do because the response is so not the best, but we'll try to make good. Let's see how it goes. For the ground again, between the stimulating and the recording electrode. Okay, now the stimulator, please. Stimulator. Okay. No, Palmer's, mixed Palmer. It'll say Palmer studies. Palmer, no, it's not Palmer. Median Palmer. Yes, that's one. Okay, so again, there are 60 cycle artifact. Just relax your head. And can you turn on the filter? Notch filter, please. Okay, just stimulator now, please. Let's see what you get the best. Yeah, so 5. Yeah, start with 5. A little bit higher. I'm not getting the stimulus artifact. Are you go to 10? Yeah, okay, now go ahead. 15. Keep going. A little bit increase. Now to 15. Yeah, so I'm not getting a response there. Is it the setting one? Okay. Go ahead. Yeah. Okay. So I don't see is the settings right? What is the 5 what?
5 millivolt per division.
Millivolt. Go to sensory. Go to sensory. Okay.
Sensory?
Yeah, go to sensory. Just go to any sensory. Yes. Go ahead. Yes. Just median sensory. Yeah.
Median digit 2?
Yes. Okay. Just record. You're setting out the machine.
There is this.
Yes. Go to stimulate. What stimulate? Okay. Okay. Now we are getting it. So the machine settings are not right. Okay. So it's close to a sensory response. Okay. So he had put it on motor settings. Go ahead, please. So, please. Increase the stimulus now to about 10. There you go. It's a very easy response to get, okay? This is a mixed Palmer response. The latency of this response, if you look at the screen, the pointer, I think we moved everything. Okay. So, you can see the latency, onset latency is about 1 point, if I'm not reading correctly, 1.8. Okay, amplitude is 11.4 over there. Let's increase the stimulus now, okay? Go ahead, just a little bit. The takeoff is not as great, but we'll get it better. There you go. It's a nice response. If you can see it, nice takeoff, okay? Nice. And then as we increase the stimulus, this is the median mixed palmar. Stimulating the median mixed nerve in the palm, recording also predominantly at the nerve. It's a mixed palmar because both sensory and motor fibers are being stimulated. Okay, go ahead. The setting now for sensory, and so you look it in microvolts. Okay, keep going up a bit. So you saw what I did. By 15, I was not getting a response, and that was not. I didn't expect that. So I started looking at the settings because settings are on machine settings. So you have to be always do troubleshooting. Go ahead a little bit. Increase the stimulus, please, to about 20 or so. Yes. So you can see it keeps going up, okay? Now go up, it can go into hundreds, by the way. Go up a little bit, are you okay? Good. Okay, go up, please.
Is this technique is more sensitive?
Okay, yes, it is. There are different ways to confer, I'll tell you about carpal tunnel because you see that.
Yes.
But I just want to show you in a second. You see what's coming over here? It's the motor response.
Yes.
Increase the stimulus again, please. And that's what I wanted to
If
show
you
you.
increase the response, we'll have the motor response.
Yes, you go high, yes. Because the lumbric, yeah. You see, it keeps increasing, and the negative peak is increasing. Okay, you see that? It's because of volume conduction. Again, I can keep going up a little bit more up to about 30. Let's stop there. That's all. Yeah, go ahead. You see what's it? So it keeps increasing this negative dip. Anyway, this let me do the ulnar, and I'll tell you the difference.
Okay.
How are we doing for time? Are we behind?
We have a time.
Okay.
I want to ask, is this technique is more sensitive in carpal tunnel syndrome?
I'll come to that question in 1 second because I want to tell you different ways to diagnose carpal tunnel.
Yes.
This is one.
Okay.
And since you asked a question, let me answer it right now. Carpal tunnel, carpal tunnel compare, so with carpal tunnel we always compare median, absolute latencies. For example, in what I showed you, my absolute latency is less than 4.2 milliseconds for motor. Sensory 3 milliseconds. Right now it's about, what's the latency of 1.8? Anything above 3 milliseconds is abnormal for my distances, okay, in mixed palmar. When you compare median ulnar sensories, pure sensory which I showed you, the median latency of above motor is 4.2. Median is less than in our labs. Each lab is different. Median sensory latency will be different from lab. It depends on the distance. Anything above 3 is abnormal. 3.3 milliseconds. So that's one way to do. We can't compare ulnar and median because they are different distances. We are comparing. So that's why when I showed you this, is because we are doing now the same nerves at the same distance. So in this technique, is the difference between the latency, I'll show you the ulnar latency in a second, is that it's very sensitive because now I'm going to record the ulnar mixed palmar response. In this one, you compare apples to apples, 8 centimeters, and you compare the latencies, not the amplitude, but the latencies. The latency difference should not be more than 3 in sublab, but more than 4 milliseconds. If this is 1.8, the difference between the prolongation of medial latency should not be more than 0.4. So if ulnar was 1.8 milliseconds, the median should not be more than 2.2 or 2.1 or 2. 2.1 is suggestive, 2.2 is definite. 0.4 millisecond difference. Same you can do for other comparisons. There are different ways to diagnose. You can also do first dorsal interosseous, compare the latency of first dorsal interosseous and APB. So let me show you the ulnar mixed palmar, and then we'll talk. A tape, please. This is not sticking. Maybe we need some. Let's go. Thank you. Sorry, I'm using a lot of your tape, buddy. Yeah. So, you take this way. I take this. Okay. Again, distance is again 3 centimeters. Okay, 3 to 4 centimeters. It's a sensory nerve settings. sensory nerve conduction settings, okay? Okay, let's do that again. Ulnar, please. So remember this value of 1.8, okay? Yes. Ulnar palmar. No, but again go to sensory settings because you got motor settings set. Okay, good, let's go. Now stimulate, please. Again, 60 cycle artifact. Can you do on the notch filter, please? Good, thank you. So always my eye on this oscilloscope, making sure the hand is rested and there's no artifact. Okay, go stimulate, please, at about 10 or so. Okay, you already got the ulnar response right there, mixed palmar response. Now there's a problem with this mixed palmar response. The takeoff is not good. I need to make it better because the whole thing is the latency, okay? So I'm going to rotate the nerve, as I told you. Now do it again. Stimulate, please. Okay, so it got worse. I'm going to go to another direction then. Now, stimulate again. Okay, so a little bit of space, please. Put a bit space here. Go ahead, please. And stimulate a bit less. Reduce the stimulation to about 10, please. Good, thank you. Now do it. So, now. Okay. And now. It's coming here. And now. A little higher, please. And just go ahead, please. Okay. So, the takeoff, I don't like it because we have to, where do I measure the latency? Okay, so that's, okay. Now do it again, please. Okay. So I've got too much. Go ahead, please. The cleaning. So trying to get a good response. In the lab setting, it's much easier because there's not that much, and you know, it's hard to get a good connection over here. But try one more time, please. You go ahead. Yeah, now it's much better. Okay. Now go and increase the stimulus, please. Okay, now just this is overstimulation. Go down to about 15, please. Okay, just go ahead. Okay, and now again. Okay. Oh, this is the motor artifact. Now you can see the motor. So the way you recognize the motor artifact is by the duration. Motor sensory durations are much lesser. And one of the ways to get a difference between a sensory and motor response is look at how this is a motor response, okay? Go ahead, please. Reduce the current, please, to about 10. Okay, now gently increase it. Okay. So I'm getting the response. Go ahead, about 12 or so. You're already getting the motor response. You see that? Okay, go ahead, please. No. Just a minute. Yeah. I'm sorry, the connections of these are not as good as I would like to. Okay, so we go ahead, please. Okay, now squeeze the stimulus. Yeah, that's good enough. So I'll take this one for now, just for example. It's not the best amplitude, but what I want to show you is the latency. Okay, what is the latency over here? Is 1.8. You see that? Remember the median latency as well? Is 1.8. It's a nice takeoff over here. This is very acceptable, although I would like to have a better amplitude, but we are not comparing amplitude to anyway. So just for example's sake, 1.8 is the latency. If you remember, the median was exactly median mixed power was 1.8. A difference of 0.3 millisecond is suggestive, 0.4 is definite. So if you are suspecting carpal tunnel in a patient, I always, if the routine motor and sensory studies are not clearly abnormal, I'll go to mixed palmar. Trust me, it's a good response and it's easily recordable. And you get a very nice waveform, and then you see followed by a motor artifact. The median one is a bit challenging because the median nerve, ulnar one, but it compares the onset latencies very nicely. Any questions about this? Good? You want to go to low limb now? Or you're tired? You want to break? Are you sure? Yes, ma'am. Okay, good. So ulnar, that's a good question.
Yeah, Nora.
The ulnar, so Okay. Can you hear me?
Yeah,
You can't hear me,
question.
guys? My wife says I speak very loud. No? Okay. Okay. So the median stimulation is right at the course of the median nerve in the palm. It comes down, gives the mixed palmar branch, and then comes down over here, right next to the hypothenar. The ulnar nerve is next to the thenar, the hypothenar, and ulnar nerve is just next to this hypothenar eminence. Okay, right here. Okay, but you can only move around. Okay, sorry, I should. And then you already know because you already done the median sensory study. I didn't go into a way how do you find the median ulnar nerve because you already done by this time. I've already done median sensory motors and I know where the ulnar nerve is. But ulnar nerve is very easy to localize. Ulnar nerve at the wrist is right at the medially. See the pisiform bone over here? The ulnar nerve is next to it, very medially, right over here. Very superficial in most people and easy to stimulate. Okay, excellent. And that's why overstimulation is very common in ulnar. What else? Are you good? You're doing good? Can you check the leg a little? The leg? Is he okay with that? Yeah? Okay. Since she's already there, I thought, why don't I show you, just a minute. We have to come down anyway. What are we going to do rep in the afternoon anyway? Since we are there, why don't we do all the demonstration right now? I'll show you the F wave and rep stims as well. How about we want to do that? Then I'll go over the theory because it'll bring him back and forth, it'll save time. What do you think, Professor? We okay with that? Professor is busy. You're okay? Should we do all the demonstration now? So that the patient is here, we've got a wonderful patient, and then we can do the lecture at the end? You okay? Because the patient is already here, she is nice.
We can continue.
Good.
And then we can take the break.
Okay. So I'm going to show you F waves and rep stims, okay? You're good? Okay. So give me some tape, some cleaning. Then we go to low limb.
Other patients' abnormality.
Oh, okay. That is mostly needle.
I'm sorry?
That is mostly needle.
No, here is also the needle.
Yeah? Okay, we'll do the needle too.
But we can do the
Needle, but needle was in the afternoon, no? I thought the afternoon, like it was after 12. I thought the morning was the sensories.
You can continue with us in the break
Yeah.
and then do the needle.
Yes, after.
Habiba is free today.
Habiba is free? Good. So I'm just going to clean it. Again, try to get a good, okay. So I want to show you the F wave, and we can talk about F waves a little later too. I heard Dr. Ahmed telling you the utility of F waves in radiculopathies. Actually, they are most useful in one circumstance. What is that? F waves, so F waves record the proximal nerve and the root. It's not just a root. So when you stimulate, I'll show you. They are most useful in early GBS, most useful. The patient's exam, nerve conduction study take a long time to get abnormal. F waves, because this has the root and proximal nerve, one of the first things I test, the nerve conduction will be normal in the first few days. Particularly in the first 2 weeks, may be normal. But these late responses are abnormal very early. H and Fs in early GBS, in the first week, you will see abnormalities. Very sensitive too, because they assess the proximal nerves. In radiculopathy, most nerves are supplied by multiple nerve roots. There's only one muscle in the body which has got only single nerve root, C5. It's the muscle at the back, okay? Dorsal scapular nerve and the rhomboids. They've got C5. All of the muscles have got 2 or 3 nerve roots. So that's why when you check the F waves, the effect gets diluted. So a single nerve root wouldn't show you F wave abnormality typically. In demyelinating neuropathies, it's very, very useful, and early GBS particularly. We also use it to follow the course. Somebody I'm getting IVIG, and I want to make sure the patient is stable. F waves are very reproducible as something we look at in addition to conduction velocities, F waves, to follow them along how they're doing clinically and electrophysiologically. So I'm going to show you an F wave right now, and we can talk about that. I'm just going to again clean it. Gel, please, and then some tape, please. You're good? Okay. So we record this when we are recording the motor potential anyway. So by this time, I know what the maximum potential is. I won't measure distance for now. Give me the tape, please. The nice. think he's applied a lot of lotion today, so it's sorry. Okay, you good? Okay, give me some tape, please. This one, thank you. This is good. This is not even sticky, man. That's why she's not. This tape is like, yeah, see, it's coming off my hand. It's not sticky. That's how I show them when there's tape. Okay. It's absolutely critical to have good connection. Otherwise, it takes much longer to get a good response. So again, belly tendon, just like the motor one, okay? I'll just, to demonstrate you, I'm just going to save time. There's so much to show that I'm just going to try to do it approximation right now, okay? See that it keeps coming off, that's the problem. Give me the stimulator, please. So if you remember, the gel, please. We had the nerve stimulated within 10 to 15 milliamps. So I already know. So let's get a motor response, please. Get a motor response, please. No, just get the motor first. Yes, please. So there you go. Thank you. Go to about 10. And there's a 60, again 60 cycle. Can you on the filter, please? There's a, yes, notch filter, please. Okay, good. What is this? A motor, median motor. Let's give a stimulus of about 5 milliamps, please. 5. Okay, I want to see the supramaximal. Go ahead, please. Okay, go now to 10, please. Okay, now 15. Yeah, there's some problem. I got it 15 last time, so I'm not getting. I'm off the nerve. Again, try again. Oh yeah, I was off the one. I was just off the nerve by a millimeter. So I could have keep going on the stimulus. So even at this stage, you can see I checked why I'm not getting this. Always check yourself. Don't keep cranking up the current. The patient feels. So the moment I knew that by 15 I'm not getting it, I looked at what's the problem. And I was off the nerve by just a millimeter. And the nerve is in between the tendons. Okay, so let's get a supramaximal response. Go to about, again, stimulate about 20. Good. So this is supramaximal, okay? So around 20, so now let's go to the F wave settings, please. Yes, please. So I know it's the same, after motor response, I've got now supramaximal, then I switch to F wave settings. The reason we switch setting is F waves take a long time to come back, and they're much smaller responses. So when I stimulate over here, the current goes back all the way to the spinal cord, and when it reaches the axon hillock, so it's a pure motor response first of all. Afferent and efferent limbs up, it's not that far. H is a reflex because afferent is sensory, efferent is motor. F response is pure motor. Afferent and efferent limbs are both motor. So when it reaches the anterior horn cell, reaches the axon hillock, it backfires. And when it backfires, 3 to 5 axons will backfire. The response is much smaller and it's much delayed after several milliseconds as compared to the motor response. So you'll see in F, go ahead please. Yeah. See, it's not the problem, it's the problem with your tape, man. It's not even sticking to my hand. How would I, do you have any of the plastic? I don't know what to do. You got tapes which are not sticky. Maybe. The paste, that's good. This is, I've got a good connection now. Let's see, this tape is coming off again. That's the problem. Okay, let's. Okay, now just relax your hand, just loose. No, that's good. Okay, let's. Yeah, 20 yes, please.
Single pulse.
Yeah, single pulse. Okay. Now, so I'm seeing an F wave right there. You see that? But go up. I'll get a few and then I'll show you. Go to another one, please. Okay. That hand, this hand, open and close. Yes, Okay, that's a nice F wave. Keep going. Give him about every 10 seconds, give another one. 10 total responses. One more. Okay. Just a minute, please. Just a minute. Okay. One more. One more. So, okay, that's fine. So, just for demonstration, although median nerves have got, you can get an F wave more than 80-90% of the time each response. It's easy to get. The most difficult to get F wave is the pronal nerve. Sometimes in F waves you can't even record pronal nerves. This is not the best, but for demonstration purpose, I'll take this for now. What you see over here is a motor artifact, motor response. Okay, the sweep speed over here is much different than this. So you get a motor response, a nice motor, and then you get these F waves. What are the features of the F waves? Number one, they've got different morphology each time because different population of anterior horn cells are being stimulated each time. The morphology is different. Their latency is different. Okay? So each time you can see this one has got a different latency as compared to this one. And one I saw was this one, a small one, this one. I don't know, I can see on the screen very clearly. This one appeared quite late, this over here. Okay, so they are much different. And we take the shortest latency, the fastest fibers. And the top one has got suspect the top one has the shortest latency. Okay, so the important thing is not the amplitude, it's the latency. The latency, we look at the shortest possible latency, and then look at the features we look at, mainly the latency. Dr. Ahmed mentioned chromosome dispersion, where shortest and the longest distance will be different in demyelinating diseases. And then we also look at persistence, how many times you can get an F wave. Okay? So the main thing is the latency, and you can see by over here, the F wave latency, what is it recorded as? I can't see from here, is about, sorry, minimum is 20 something, 20?
Latency, M latency.
M latency, no, F wave latency, no, M latency. No, F, sorry, F. F is, it says 21 milliseconds, right there, right there. Okay, so F wave latency, is that right? Am I right? Minimum F wave latency? Okay, now sometimes, just give me a second. Can you use a marker, this one on this one number, whatever number this is? This one, yeah, yes. Use them, and can you bring this marker yeah, bring it to right where the takeoff is. There you go. Keep going. Right there. So you see how is he marking so you can mark the minimum possible F latency, and ideally would like to see two F waves similar. And you can see over here, two F waves are similar. Sometimes in neuropathy you can only get one F wave or two F waves. Ideally, we would like to see two F which have got a similar morphology. And this one and this got a similar morphology. And you record their minimal possible latency. F waves, I told you, the utility is in demyelinating neuropathy, early GBS, radiculopathy is not as great, and to follow the course of neuropathies. Any question about F waves? What I was doing over here, so when, you know the principle of cross inhibition or cross facilitation. So when I was doing this, on the other hand, I was facilitating the anterior horn pools on the side I'm recording. It facilitates F waves. It distracts the patient. It's hard to get in sometimes very anxious patients. It distracts the patient and also causes facilitation of the anterior horn cell on the opposite side. And so, you know, there's cross inhibition. When this muscle contracts, this one relaxes. There's a connection in the spinal cord. We won't go there. But this, by doing these maneuvers, clenching the teeth, contracting the other side, we can facilitate the F waves. Okay? Yes, please. So he's asking, is there any effect of exercise on the nerve conduction? Depending on what you mean. I'll show you the effect of exercise on rep stims. When we do the exercise, it does change a lot of things right before, and we show you in the myasthenia protocol. In long term, you got bigger muscle, maybe a bigger amplitude. Bigger the muscle, bigger the amplitude. Okay? Any other questions?
Should I consider this an inconsistent F wave?
No, not in this setting. But if in a median nerve, you're getting 3 responses out of 10. So we typically do 10 F wave check, and Ideally, you should get 80 to 90%. It should raise, in this patient, should raise the concern that why you're not getting enough. If I'm concerned, I'm going to check it again, okay? In ideal lab technique, okay? Don't overcall things. That's why you want to make sure that, but if F wave is persistent, one finding does not describe the whole study. That's called overcalling. You want to confirm it. If you're calling F wave in persistence, you're suspecting a proximal issue with the nerve or nerve root or whatever. There should be something else. This can be F wave in persistence in a setting where you're having other abnormalities. So they should all match. If with completely normal F waves, it's also physiologic. Patient may not be relaxed or whatever. So this alone won't make a diagnosis of a disease. For long F wave latencies, particularly, so ideally it depends on the arm length, okay? It again depends on the length of the arm, the values. Anything above 32, 33 is abnormal. In a person who's 6'5", tall, we go up to 34, 35 milliseconds. In the lower limbs, anything above 62 is abnormal, okay? But in this patient, you can't apply that rule. So it's more important for her when we follow what's her latency. If it's 20 and it's like, for her maybe 32 may be abnormal, okay? Because of the arm length. And so it's important to be of the physiologic factors as well. We'll go over that later. So we're good with F waves, guys? We'll go to low, okay. So we'll do, since we have motor settings, we'll do rep stim right now, okay? Rep stim is critical because it is very dependent on the technique, okay? Very, very dependent. So go to rep stim mode, sir. And so we already have a motor response. I want to confirm that before I do that. It's again that, so rep stim. Are you want to take a break, guys? Or you're tired? Okay. This is the water. Water, please. Water bottle. So repetitive nerve stimulation is one study which makes a diagnosis within our mind. It's very satisfying. You get an abnormal median rep stim, you get the diagnosis right there. Most cases. I'm trying to exaggerate that. Rep stim is very satisfying because you get a diagnosis in a patient within 3 to 5 minutes. In neuromuscular disease, that's pretty good, isn't it? You don't go for genetic testing, you don't do whole body MRIs, you get it right in the EMG lab, okay? So, yeah, so it's very technically, it's very challenging study. There are a lot of artifacts that can be introduced. We'll go over that in a second. I'll show you the technique, and then we'll talk about the theory of that, okay? Setting is the same as motor. It's a compound motor action potential. You already know the supramaximal stimulus, okay? So we already know for this muscle, the supramaximal stimulus was around 20. But whenever I go to rep stim, I always make sure that I have got I have stimulating. First of all, the most common artifact in this testing is movement artifact. Movement of your stimulating electrodes, movement of your recording electrodes, because the moment you are going to repeatedly stimulate, if there's movement, if it gets off your stimulator or your recording electrode, it won't be supramaxillary stimulus anymore. You will introduce an artificial decrement because of that movement, and there are ways to pick it up, and I'll show you how to pick up artifact. But any movement will introduce, so you want to make sure everything is nicely fixed and not moving, okay? The patient has to be fully relaxed because each time. But anyway, let's first of all record a motor stimulus. Can we get a motor response, please? I want to make. No, motor, please. We are done with F wave, please. Just a routine motor, please. Go to median motor, please. Okay, so I'm going to do median motor just to make sure that before I keep giving her electric shocks, I want to make sure that everything is good, okay? Now, go to median motor, please. Give me 20 milliamps. Okay, here we go. You good? Okay. Always warn the patient because they will. Okay. 10, go to 10. Okay. We got a response, but 60 cycle is a lot there, despite, okay, stronger. Okay. Just, are you on the median motor? Okay. Go again, please. Okay. Now we are getting a 10. Go to, I was again off by 2 millimeters. Go to 15, please. No, 15. Thank you. Okay, this is supramaximal. Just to make sure that I'm going to go to 17 or so. Go to 17, please. 17 milliamps, please. Good. Good, it's not changing, okay? Now go to rep stim mode, please. Rep stim. 3 hertz, okay? Remember we talked about this? So put it at 3 hertz. So the stimulus frequency, we repeatedly stimulate the nerve at different frequencies. The best decrement you get is at 3 hertz, 3 per second, 4 per second. I'll tell you why later, theory, but the setting is about 3 hertz. So she'll get 3 stimulus per second. So I want 3 hertz and a train of 6, not 10. And a train of, so some lab use a train of 10 stimuli. I can do that. It's more uncomfortable for the patient. I reduce to 6, I'll get the answer in 6. Typically, you can get the answer in 6. And in my lecture, I'll tell you why 6 or why 10. But just for our comfort, we'll make it 6 at 3 hertz. How many? This, 10 what? 10, no, we were at 17, remember? Go to 17 or 18. And how many per train? How many? 10. No, go to 6, please. So she'll get 6 stimuli at 3 hertz, so 2 seconds. Can somebody explain to her in Arabic? She'll get repeated stimuli. Who can? Ask her not to contract her hand, not to, just keep it relaxed. Okay, just relax. Okay. Go ahead, please. 6. Okay, you ready? Excellent. So you can see the 6, a train of 6. Can you change the sweep speed, please? To what is the sweep speed? Go to 2 milliseconds per division, please. Okay. I'm trying to pull it out open and increase the gain, please. What is the gain now?
500 milliseconds per division.
No, it's not the gain, microvolts. Go to 2 microvolts, please. 2 millivolts, sorry. There you go. And reduce the sweep speed even further. No, the other way. You do, and further up, maybe even. Go to 1. I'm just trying to exaggerate this, okay? And sweep speed. How much is sweep speed? 1 no, sweep speed, the seconds, yeah. Go to 1, please. No, sorry, go to, yeah, that's good. That's sure. Little less back. Okay, what I want to show you over here is the following things. So what you see, this is called the rep stim mode, okay? And do it one more time, please. Let's go to the 6 again, please. One more. Yes, please. Okay, so what we are getting is, you look at the waveforms. Are we good? Are we good over here? Okay. So what you get is, the waveforms is stable. There is no change in the morphology or amplitude, okay? So there is no movement artifact. The baseline is good, sharp rise time, and the waveform does not change in morphology, okay? What is the size? What is the amplitude over here of the waveform? Have you marked them, waveform?
8.4.
Okay. Okay. So it records this is the first stimulation, okay? Now what I want to do is to get it after exercise. So this is the baseline. We exercise the muscle for about a minute to see what happens, okay? Ask her to lift her thumb up. Up. Push my finger up. Up. No, she's going the other way. Up. Push up my finger. Yeah, that's good. Good. No, she's doing good. I can tell you. Good. Keep it there. Yeah, good. She's okay. Yeah, ask her to keep going. And now I can see my electrode moving a bit. That's the problem with exercise, the move. So if you're not fully, and I can see my recording, but we'll see, just to show you. Okay, I'm just going it for about, we do it for about 60 seconds. What this is called facilitation. It builds up the calcium in the neuron, in the muscles, and then it increases, called facilitation. But after a minute or two, because you're using the acetylcholine, it'll show you the decrement which will be increased after post-exercise, called post-exercise exhaustion. So you try to utilize all the acetylcholine stores, which are not all, but in normal people, it doesn't change, but in patients who already got abnormal transmission, that reduction in the acetylcholine stores would make the decrement more manifest, make it more appear. Let go, just relax. Now give stick stimuli immediately. Just give me a second. There's too much movement, man. This is not going to work. Yeah, everything has moved. Yeah, it's not, but anyway, yeah, these guys, yeah. How do you do with, okay, go ahead, please. Go to, so this is the problem when you see the tape is not, what are you going to do? Give me a tape. I told you that, no, enough space, man. Okay, let's try one more time. Go to repeated stimulus mode, please. Yeah, same, everything same setting. Repeat. What's amplitude now? Yeah, I think the mood I can't show you over here, but yeah, and in fact, by the way, there's an artificial decrement taking place. If you increase the, now this is an artifact, here we go. And I'll show you in the lab, you increase the, you see there's a little bit of decrement over there, this one? You see this? This can easily be, this is artifactual. This can easily be, I'll tell you why it's artifactual. There's a problem. The most decrement occurs between the first and second potential, first and second. Over here, the first and second, the most decrement is happening between 3 and 4. So the rule of decrement, since we have already found an artifact, when you see a decrement, the most decrement occurs between the first and second stimulus. It maximizes by 4th or 5th, and that starts recovering. It's called a U-shaped envelope. Between when you look at the tracing, always in RepStim, you look at between the first and second. The maximum decrement visually should be between this first and second. And it should keep worsening, and by peak, it should be 4th. And 5th, it starts recovering, 6th, 7th, 8th, 9th, 10th, it recovers. That is the decrement which is pathologic. Over here, what I see is there's some decrement, but maximum decrement is between this and this, maybe second and third. So this is a movement artifact. Either one of the electrode recording or is moved from this, and so you're getting an artifact. And this is very important. So whenever you get a decrement, the first thing you do is look at the waveforms. Look at this waveform. The first you can see it's going down. Where is it going down? Is it going down between first and second maximum and then going further down? Or so the machines are programmed to look at the first and fourth stimulus. It'll tell you, yeah, there's a decrement. If you compare this one to this one, the machine will tell you there's a 10% decrement. But that's not the problem. The machine is automatically will read that, compare the two potentials. Your job is to look at, enhance the waveform, see where the decrement is taking place. And it should be maximized, I told you, between first, second, and maximizing by 5th decrement, okay? So this is the theory of RepStim, but again, beware of the technicalities, okay? The technical part is having the patient fully relaxed. She is cooperative, but unfortunately, we'll do it one more time just to see if we can get a better, but you now know 3 hertz is the wear. If you do it at 10 hertz, 3 hertz is because there's enough time for the acetylcholine to be depleted. If you do it faster frequency, calcium will build up, more acetylcholine will come into the axon terminal, and you won't be able to see the decrement. That's why in LEMS, we do increment. We do a fast frequency stimulation. In fact, we want to build up the calcium. The problem is presynaptic. We want to build up the calcium in the axon, as compared to myasthenia, where we want to run out of the acetylcholine. So 3 hertz to 4 hertz is the ideal frequency. It's enough time for acetylcholine to be. Maximum 5 hertz. 6 is the minimum train you want to use to see that recovery pattern. At 4, you are able to see. 5, you'll just see the decrement, but not the recovery. Ideally, you should see the recovery as well. So decrement, and by 5th, it starts recovering. By 6th, 7th, you should get a U-shaped envelope. Okay? So that's why we use that trains and frequency of stimulation. exercise is very useful because one of the things which happens with exercise, you want to see, another thing, quality control in rep stim is you want to see what happens after exercise. Ideally, if you're getting a decrement at baseline, after exercise you should get some facilitation. The facilitation should improve the decrement. That's the first quality check. After the second quality check is where is the decrement maximum? Is that by the second, by third, so you do it baseline, exercise 30 seconds to a minute, immediately after the exercise, then you do every 30 seconds, about 6 times. So by the second 2 minutes or 2.5 minutes, the decrement is going to maximize. So baseline decrement, improvement post-exercise called post-exercise facilitation, and then after every 30 seconds, you keep doing the train. By 2 to 3 minutes, the decrement is going to maximize. And by 4th, 5th minute, it'll start improving. Well, and you'll see improvement. This is because of normal physiology. What happens is when the axon is running out of stores of acetylcholine, further acetylcholine is transported down the axon into the terminal. So that amount of time shows you the recovery. So when you're looking at it, again, just to repeat myself, first you look at within the train, intra-train decrement. Maximum between the first, second, maximizing by 4th, 5th, and improving by, that's the first quality. Secondly, the pattern of decrement. Pre-exercise, post-exercise, it not done happen, and it should be persistent. It shouldn't be that at 1 minute after exercise, you're getting 50% decrement, and 2 minutes you get 20%. Like, it should not be up and down. It should have a smooth pattern. So let's say that you get a decrement of 15% pre-exercise. Post-exercise, the decrement improves to 5%. By 1 minute, it should go back to 10%. By 2 minutes, 15, 20%. By 3 minutes, 25%. By 4th minute, 20, 18, and then by 5th minute or so, it should go back to about 10%. See this pattern? Slow and then nothing in jumping. If your technique is right, this should follow this pattern. If you're not following this pattern, intra-train or inter-train, there's a problem. So look at the train itself and the intra-train and inter-train. Good? That's clear? Okay. Again, very sad. You can get a diagnosis within the first muscle. We can do it in a trap. I can do it but I wished I could maybe, if I could have shown you in the face, but not the right time and right patient, and there are a lot of technical factors. But very easily done in the face. In fact, face is the nasalis muscle is the most sensitive in myasthenia. It's easily doable. We stimulate here, record there, very easily doable, and done very quickly. Minimal 3 muscles. Hand muscle, 1, trap, nasalis. Sometimes I do 4 muscles if I'm, because the next step is single fiber EMG. You know what single fiber EMG is? Anybody does it over here? But I can show it, but that's another. So I know what it'll take my 2 hours. If I do go for single fiber, it'll take me 2 hours. So I want to get the answer here, because if I get the answer here, I don't need to go for single fiber, because it shows the same thing. So I want bend backwards if a patient comes to get a diagnosis with rep stim rather than single fiber. Okay? So anyway, this is it. I'll show you one more time just to make sure that, okay, can we do it one more time, please? Let's see if we can, it's just a rep stim. And I'm not sure there's a problem with this machine, because you can see this, I don't know why this is, 6 should be all, over here you see all 6 similar. I don't know why the first is not this low. I don't know why it's reading that low. There's a setting problem. You see this? This shows this picket fence appearance shows you the amplitude of the motor responses. I don't know first is so low because that's not low over there. You can see it. So there's a problem there, but I'm not going to. So this helps. All machines have this diagram, this picket fence, to see what's happening. Okay? But I saw the first time as well. This is low, and I know visually that's not correct because I can see the first response being pretty good. Okay? But anyway, we're going to. So let's try it one more time. That's 6. Okay, so this one is better, but you still see the first one. But you can see again, it's very reproducible. If you've got nice attachments, you can see how nice it appears. Okay, and you can easily see that if you enlarge, reduce the gain, please now. So to see the so maybe this Yeah, that's good. But no, just not millisecond, but millivolts. Go to 2 millivolts per division on the right. This one. No, on the right, further right. This one. 1 millivolt, yeah, this one. Reduce it to 2, yes. So normally you will have this one, okay, at 2 millivolts per division or whatever. But if you want to see the decrement, you can enhance the nerves to see is there a true decrement by looking at the waveform themselves. So I always enhance the waveforms to see where the decrement is happening. And it looks pretty nice. You can even publish this because this looks pretty stable, there are no artifacts. Main artifact I showed you is the most critical. Temperature, decrement, I'll tell you, I'm giving my lecture over here as well. Decrement, if you got a cold limb, what will happen with cold limb? The easy question is what will happen? It will mask the decrement or worsen the decrement? Cold limb. If you had a cold limb, if you let the temperature go 26 on the hand, what will happen to the decrement? Decrement will worsen? The decrement will not show up because you will artificially, there are multiple reasons. The reasons are there will be artificial buildup of calcium in the axon terminal. The acetylcholinesterase, which is breaking down the acetylcholine with cold limb, enzyme level will go, activity will go down. So in fact, you can mask the decrement in the cold limb. The limb has to be warm. Sodium channels be open longer in a cold limb. So you more cold entry, there will be more time for sodium to enter the cell. So there will be build of sodium, there will be build of calcium, there will be reduction of the cholinesterase enzyme. So cold limb is a big no-no so you have to have the limb warm. Okay, there are multiple reasons. Good. I think I've done enough about rep stim. How are we doing? Guys, you're tired? We're just starting. 11:45. Want to go to lower limb or you want to take a break? Break? Yes, I heard that. I can see. Everybody says, guy, give me a break. Okay, all will get a break. Thank you, guys. Okay. Is it going okay? Guys, get me a better tape, man. For God's sake, this tape is...